Okay, so let's talk about something that is much more common than scleroderma. Okay, osteoporosis. So, what is osteoporosis? Demineralization of bones throughout the body, resulting in fragile and weak bones. So, if you think of bones as being composed of a matrix that has calcium and phosphate in large quantities, giving it a lot of strength, the bones are becoming demineralized. Okay, so as the bones demineralize from calcium and phosphate, and there's thinning of the bones, they become much weaker and they have much less density. Okay, so decreased bone density in osteoporosis. Much more common in women, especially postmenopausal. Estrogen is very protective to the bones in terms of not developing osteoporosis. So after menopause, when estrogen has stopped being produced by the ovaries, bone loss and osteoporosis can develop in the first 5 years after menopause. Okay, where are the most common sites of osteoporosis? Well, we see wrist fractures all the time from minor falls. Hips are a very common area. Vertebral spine. So we see fractures very commonly at these three areas: wrist, hip, and vertebral fractures because of the osteoporosis. Okay. In fact, I think I mentioned that in some women, sometimes just bending over to pick up something, they could have a vertebral fracture because the bones have become, they've lost so much density. Okay. So what's the gold standard test to diagnose osteoporosis? So it's certainly not an X-ray. By the time we see osteoporosis on an X-ray, it's typically really severe osteoporosis. So the test that we use to try and pick up osteoporosis much earlier is a bone density test. Okay, and they'll put a beam through at the vertebral column or the hip area, or sometimes at the ankle, uh, the bone next to the ankle called the calcaneus, and they'll see how dense are these bones. Okay, and then we'll get a readout in terms of whether the person has normal bone density, some osteopenia, meaning they've lost some bone density, but not quite osteoporosis yet. So normal bone density, osteopenia, meaning some loss of bone, and then finally osteoporosis. So if we think of osteoporosis, let's just think about the cycling of the bone first. So bone is constantly being produced by osteoblasts and broken down by osteoclasts. So it's a constant cycle of changeover of the bone. Okay. Now, um, as um, as we age, the osteoclasts tend to break down the bone faster than the osteoblasts produce bone. Okay, so it results in osteoporosis. And this is most commonly seen in, as I mentioned before, postmenopausal women because the estrogen is very protective to bone breakdown. Okay, so with that loss of estrogen, the osteoclasts break down bone much faster than the osteoblasts replace it. Okay, so with the loss of this cancellous bone, reducing bone density, uh, patients are at risk for pathological fractures with very minor injuries. Okay, so really, Osteoporosis is asymptomatic until you start to get fractures around the body. So if the fractures start to happen in your in your thoracic spine, for example, well, you're going to get kyphosis, such as the image at the bottom right. Okay, that's from vertebral compression fractures. Or someone will come in with a relatively minor fall, and they'll have a displaced wrist fracture, or they'll have a hip fracture. Okay, and often it doesn't take much force. Okay. Patients lose height with osteoporosis, right? And why are they losing height? Well, from compression fractures. Not only are they bending forward, but with the compression fractures, they're actually losing overall height as well, okay? And we can call that kyphosis a Dowger's hump. Typically, we refer to it as kyphosis of the thoracic spine. Okay, so this is just showing you bone mass in males and females as we age. Okay, so we peak at around 30, and then there's a very gradual decline in bone mass over the age of 30. And then at menopause, so if we look at females, at menopause, look how steep the curve begins going down. They lose a lot of bone mass after menopause because of that estrogen loss. Now, overall, males have more bone mass to begin with. So we can tolerate more loss of bone over time. Okay, so if you look at the age of 60, sure, males are losing bone mass as well, but we started with a higher overall bone density, so we're still at a good level, even at the age of 60, okay, compared to women that have lost significant bone mass after the age of 50. Okay, and that's why they're at higher risk for fractures and osteoporosis because of all that bone mass that's lost after menopause. Okay, just some risk factors for osteoporosis. So on the left, non-modifiable, so advanced age. Well, just the process of aging is a risk factor for males and females for osteoporosis. Female gender for sure. White or Asian, higher risk factor. They tend to have an overall lower bone mass to begin with. Okay. So well, there's the next risk factor, low peak bone mass. So when you're 30 and you have a very small frame and you have very thin bones to begin with, your overall peak bone mass was low to begin with, right? So by the time you get to menopause and afterwards, you've really lost a lot of bone, okay? Because you weren't starting off at a high level. Family history of osteoporosis, definitely, often because you'll have a similar frame, a skeletal frame as your parents. Okay, so there is a family history component to osteoporosis. Personal history of fractures. So if a woman has had wrist fractures and hip fractures, we're really suspicious that this is going to be from osteoporosis, okay, or at least osteoporosis is contributing to it. So someone with a personal history of multiple fractures, we would think that they probably have fragile bones to begin with. Okay. What's modifiable? Well, smoking. So smoking causes decreased oxygenation over time to the bones. So the bones don't get as much bone mass, right? So smoking basically replaces oxygen, right? There's carbon monoxide in smoke. Inadequate calcium intake. So as we're reaching peak bone mass, so as a child in our teens, 20s, 30s, we want to make sure that we're getting proper intake of calcium and vitamin D to build the bone, to get to a good peak bone mass, right? So if someone had poor or inadequate intake of calcium and vitamin D as a child or as a young adult, that is a risk factor for osteoporosis later in life, okay? And also, if someone's in their 50s or 60s and they're losing a lot of bone mass because they've lost their estrogen, so I'm talking about females, taking calcium and vitamin D supplements is extremely important to try and maintain some of that bone mass, okay? Modifiable, so estrogen deficiency, well, it is modifiable if you have, say, early menopause, or you had to have surgery to have your ovaries removed at a young age, such as in your 30s or your 40s. You would be put on estrogen replacement for the very fact of protecting the bones from early onset of osteoporosis. Okay, so if someone had their ovaries removed in their 30s, you can imagine they're going to start losing bone at a faster rate in their 30s. So they're at very high risk for osteoporosis. Okay? Or any condition where estrogen is deficient in the body would be a modifiable risk factor, since we can supplement estrogen as a medication. And the last one, really important, chronic use of corticosteroids. So glucocorticoids such as prednisone, dexamethasone, for an assortment of conditions such as rheumatoid arthritis, systemic lupus. We use them for so many conditions, and we're very conscious of the fact that they cause increased bone breakdown, leading to osteoporosis. So if someone's taking a glucocorticoid for a prolonged period of time due to another condition, we make sure that we put them on calcium, vitamin D, and actually other osteoporosis medications to protect their bones from the glucocorticoids. Okay, so how can someone prevent osteoporosis? Well, there's a number of ways to fortify the bones to protect from decreased bone density. So supplementation with calcium, typically about 1,000 to 1,200 milligrams per day of calcium, and as well vitamin D. And that's typically about 800 to 1,000 units of vitamin D per day. Okay. Exercising regularly, whether it's walking, hiking, whatever somebody likes, because regular weight bearing, so regular exercise and weight bearing exercises provide force through the bones, and when the body detects use of the bones, it will make sure that there's proper deposition of calcium and phosphate on the bones. So if someone's not exercising regularly, they're going to lose their bones more rapidly, leading to osteoporosis. So definitely regular exercise. And as I mentioned, weight-bearing exercise are very important. Okay, stopping smoking, again, can prevent osteoporosis. Minimizing alcohol consumption. Alcohol is linked to so many things. It's also linked to osteoporosis. Okay. Okay, so in someone with osteoporosis, well, the bone loss can be slowed down, or actually it can be very gradually reversed. Okay, so the goal of certain medications, such as calcium and vitamin D, is to not only slow down the progression of osteoporosis, but to actually try and stop it, to level it off. Okay, And with exercise, that can certainly help. Okay, so when patients go for regular bone density scans, typically every 2 years, they can compare the bone density from of the current one to the previous one 2 years ago to see if there's been any further deterioration and worsening of the osteoporosis, or if it's leveled off. Okay, and exercise, calcium, and vitamin D can definitely help level off the losses. Okay, now sometimes we can see gradual improvements of bone building, so a bit of a reversal of osteoporosis. Okay, so that can happen by doing these activities as well. So exercises, calcium supplements, and vitamin D supplements. And now there's medications called bisphosphonates. And what do bisphosphonates do? Such as alendronate or risedronate. Well, they inhibit osteoclast breakdown of the bone. Okay, so these are very commonly used in osteoporosis or in patients that are at high risk of developing osteoporosis, such as someone on long-term corticosteroids. And they inhibit bone breakdown by blocking the osteoclast. So these drugs can be added to regular exercise, calcium, and vitamin D supplementation. Okay. Lastly, calcitonin, not as commonly used because the bisphosphonates have been shown to be more effective. Okay. What does calcitonin do? Well, it inhibits osteoclasts and can also stimulate the osteoblasts. So, well, that makes sense. That can help with some improvement in osteoporosis, or at least stabilization of the bone loss. But the bisphosphonates have been shown to be more effective. Okay, on to a new inflammatory condition called gout. And gout is caused by a crystal of uric acid. So in our bloodstream, we have uric acid. And where does uric acid come from? Well, it comes from the breakdown products of nucleic acids, so DNA. Okay, so when cells are breaking down, they release their DNA, and as part of the breakdown process, we get uric acid circulating in our bloodstream. So if we have elevated levels of uric acid, we're more prone for the uric acid in our bloodstream to make it into joints. And when we get uric acid crystals depositing in joints, in particular, by far the most common one is the big toe joint, it causes intense inflammation. Okay, so the body recognizes these uric acid crystals and attacks them with intense inflammation in the joint itself. Okay, so what's the cause? Well, the cause is typically hyperuricemia, elevated uric acid levels in the bloodstream. Okay, and that elevated level puts someone at higher risk for deposits of uric acid in the joints, leading to gout, in soft tissues, leading to deposits of gout or of uric acid in the soft tissues, and also deposits in the kidneys. So, and we can develop uric acid kidney stones, right? So elevated uric acid causes gout in the joints, what's called tophaceous gout in the soft tissue, these lumps that are filled with uric acid, and uric acid kidney stones. Okay. So as I said, these joint crystals of uric acid sets up intense inflammation in the joint, and people are really miserable with this condition. They can barely walk on this inflamed toe. Now, Does it have to affect the big toe? Not necessarily. It can affect, in terms of frequency, it affects the big toe the most, but it can affect the ankle joint, the knee joint, it can affect the wrist joint, not as commonly as the big toe. Okay? And patients get repeated attacks of gout. And with repeated attacks of this intense inflammation in the joint, whether it's the big toe or the ankle or the knee joint, they're left with gradual arthritis because every attack of gout causes some joint injury. So finally, the joint can become arthritic over many years. Okay, so what can trigger a gout attack? So we spoke about the fact that gout is typically caused by an elevated uric acid in the bloodstream that then the crystals deposit into joints, setting up acute inflammation. So what's going to trigger an acute attack of gout? Well, certain foods can trigger a gout attack, such as organ meats, so kidney, liver, very rich foods, seafood, and there's alcohol again. So alcohol is a big trigger for an acute gout attack. Okay, so and that can be a problem for many people because after a weekend of drinking alcohol, they come in on Monday or Tuesday with an acute flare-up of gout. So think of very rich foods, especially meats, that are a trigger for a gout attack because of increased uric acid consumption. Okay, and typically gout is in middle-aged men or postmenopausal women. Okay, why postmenopausal women? Well, estrogen is a bit protective for minimizing uric acid levels in the bloodstream. So it's uncommon to see a young female with a gout attack. So it's usually men that get it more often than women until menopause. So how do we treat gout? Well, for the acute flare-up, we use anti-inflammatories, such as ibuprofen and an assortment of other ones. Okay, and that usually really settles down the gout attack. Now, if someone's getting repeated attacks of gout, say 5, 6, 7 times a year, we can start them on a medication that will reduce the level of uric acid in the bloodstream, but they have to take the medication every day. Okay, and we'll talk about that medication in a minute. Lifestyle changes. So weight loss can help. Changing your diet by avoiding the foods that we just mentioned, and also decreasing alcohol. So let's just go back to the treatment again. I mentioned NSAIDs for acute flare-ups of gout. There's another medication that you'll likely hear of in pharmacology called colchicine, and we can use that for an acute flare-up of gout. And sometimes, if we can't use NSAIDs because they have, say, an ulcer or they have kidney disease and we want to avoid NSAIDs, sometimes we'll use a glucocorticoid, such as prednisone, to settle down the inflammation. Okay. Allopurinol is a medication that lowers serum uric acid, and it reduces the number of acute gout flare-ups in a patient. So if someone was coming in 6 times a year for acute gout flare-ups, we could reduce that number by starting them on allopurinol long-term that they have to take every day to keep their serum uric acid levels lower.